Welcome to Decoding DX. We're a group of fourth-year medical students with a passion for education and patient care.
This episode of Decoding DX is for educational purposes only and should not be used as medical advice. Please consult your healthcare provider for any medical needs.
The opinions expressed represents those of the participants and are not of our affiliated institutions.
Thank you for joining us on Decoding DX. We keep learning so much through this experience, and we're so glad that you're learning alongside with us. Now, let's get to the episode. Welcome to 10 Clinical Minutes. Today is part one of a two-part series on narrow complex tachycardia. And before we get started, just to make credit very clear, this presentation was largely based on a presentation on diagnosing narrow complex tachycardia in the HM20 virtual conference by Dr. Megan Mary Walsh. And all the EKG examples were from Life in the Fast Lane, which is a great resource for any sort of EKG learning. So to break it down, the differential diagnosis when you have a narrow complex tachycardia, the biggest two categories you need to think of are, is it regular or is it irregular? Each of those categories then has subcategories that you need to go down, but that's the big branch point that you need to figure out first. And today we're talking about those with irregular rhythm. First things first though, when the situation is urgent, you need to treat before you diagnose. If the patient is hemodynamically unstable, first you just need to figure out, is this sinus or not sinus? And if there's any doubt about that, urgent cardioversion is always the answer. If it is sinus tachycardia and you can be sure about that, the best treatment is to treat whatever's going on. Sometimes that might need IV beta blockers or other IV therapy, but if there's any doubt at all about it being sinus, cardioversion is the answer if they're hemodynamically unstable. If they're hemodynamically stable, on the other hand, that's what we're going to be talking about in this video. And that gives you a little bit of time to be able to examine that EKG and figure out what actually is going on so that you can treat that specific diagnosis. And as a little aside, if that EKG is too shoved together, meaning if all of the QRS complexes are too close to be able to figure out the underlying rhythm, you can do a variety of different strategies to try and spread out those complexes so that you can then make the diagnosis of the specific arrhythmia. And the various things that you can do, the least invasive is vagal maneuvers. So that includes, rubbing one side of the carotids. That includes deep breathing, all sorts of things to try and just get that heart rate down. Or you can use medications. So here are some of the more common urgent dosing regimens for some of the most common medications to try and slow down that heart rate. So adenosine is a very, very rapid acting and very short lasting medication that essentially makes the heart stop for a few milliseconds. You can do this a few times, but again, you need to warn the patient. It's going to feel kind of weird because their heart is actually going to stop beating. You can also give IV metoprolol, diltiazem, or amiodarone, and the dosages for that, they're most commonly used in the urgent situation or in this table, and you can pause and take a moment to look through this if you want. But always make sure you look up the most appropriate dosing for what clinical situation you're in. Okay, so if we're going to actually figure out what is this underlying rhythm going on, the three big questions that we need to address. First of all, is it regular or irregular? Second off, what's going on with the P waves and the isoelectric line? And then third off, what's the actual pattern of the rate variation? And if you can answer those three questions, you can figure out what the arrhythmia is. So really big chart, really daunting. We're going to split it up. So this presentation is going to be about the irregular side of it. So again, in the orange, we figured out it's irregular, looking at the QRS complexes. Next, we're going to look at the P waves, and that's the blue boxes. And then after that, we're looking at the variability, and that'll be in the black boxes. So to start off, multifocal atrial tachycardia. Essentially what this is instead of just the SA node controlling the rate of the atria, there's multiple different spots where that electrical impulse is starting from in the atrium. So that's what it means by ectopic foci, is that there's a different origins of that electrical impulse other than the AV node. So when you look at your EKG, you're going to see three or more distinct P wave morphologies. That means that the P waves are going to look different. So if you look down at this example EKG, you can see where the arrows are pointing, that those are P waves, but they look very different from each other. And that's because each of those is coming from a different origin. In between these abnormal P waves, you'll have a normal isoelectric line. Now, if the heart rate is too fast, that may be kind of hard to determine. But if it's slow enough, then you can see that normal isoelectric line. The heart rate in this case is normally about 100 to 150. And in most cases of MAT, it's associated with COPD or congestive heart failure. What do you treat? Well, in reality, this is oftentimes asymptomatic. It's something that you'll just find incidentally on EKG or on telemetry. What you need to do is treat the underlying disease. So if it's COPD or congestive heart failure, you need to treat that medically and do what you can to prevent worsening of any sort of condition. So you want to keep your potassium in your mag normal. If the patient's having symptoms, you can rate control them. So that would be done with a beta blocker, diltiazem, or verapamil. But in this condition, there's really no indication for cardioversion or antiarrhythmic drug. Next up is atrial fibrillation. This is a rhythm that even a lot of non-medical people are aware of. So this is what we classically think of as the irregularly irregular rhythm. But the key here is that there's no actual P waves and there's no actual isoelectric baseline because the atrial muscle is essentially just kind of freaking out. It's just kind of buzzing all around and there's no clear contraction or coordinated effort by that atria. One thing to note is that the fibrillation waves can be on a spectrum. So they can be really fine or they can be kind of coarse. And when they're coarse, it can be kind of confusing because it can actually mimic P waves. So you really have to take a step back, be careful. If you're questioning it, get another EKG, or if you have a telemetry strip, look at a different part of this telemetry strip to see if you can help discern what's going on. So again, you can look at this example here. It's irregular, meaning that the spacing between the QRS complexes is not consistent. So there's a different distance between each QRS complex. And it's doing that in an irregular pattern. And so that's not like something where it's double the space and then one time the space and then double the space and then one time the space. In actuality, there's not really any pattern that we can discern from looking at the space between these QRS complexes. And that's what it means by irregularly irregular. One thing to note, atrial fibrillation can be with or without the presence of RVR, which is rapid ventricular response. And this is largely dependent on basically just how often that atrial electrical activity is getting through the AV node, how often the ventricles are contracting. So there's actually a lot of people that live their lives perfectly fine with atrial fibrillation, but just their ventricles are working at a normal rate. And so they're not feeling it, it's asymptomatic. And as long as they're being properly managed with medication like blood thinners, then it's perfectly fine. Atrial fibrillation in a lot of situations is not something that we have to actually get rid of. So talking about the treatment, it's very nuanced. This is very much so its own topic. You'll definitely want to use the CHADS-vasc score in anyone with atrial fibrillation. That'll help you determine whether or not they need anticoagulation if it's non-valvular A-fib. There are situations where cardioversion is indicated in A-fib. Some common situations that you might think about would be if someone is very young, if this is a new onset A-fib and we know the cause, it's not just because of like an dilated atrium or something like that, but there's a clear cause that we can identify. Or if this person has clear symptoms from it, symptoms that aren't abating, and it's causing other effects such as worsening their heart failure or things like that. So there's a variety of situations where cardioversion is indicated. You can do that with electricity or with medications. Commonly, we'll try medications first, like amiodarone. Digoxin also can be used to try and control the rhythm, but again, that's definitely not a first-line treatment. More often than not, though, we treat these patients with anticoagulation and with rate control. Commonly with beta blockers, you'll also see diltiazem or sometimes even verapamil, which is a common thread that you'll see. Rate control equals those three medications in a lot of situations. Next is atrial flutter with variable conduction. So there's two types of atrial flutter. There's with variable conduction or with constant conduction. So in atrial flutter, the atrial rate is going to be right around 300 beats per minute. And this is a fairly consistent thing that we see because of the pathology of what's going on with atrial flutter, which is a re-entry circuit within the right atrium. So there's something going on that's causing this loop of electricity to go round and around the atrium. And because of the size of the right atrium, that's why we get the 300 beats per minute. So we'll see these flutter waves, which is the classic sawtooth pattern. Normally, they're best seen in leads 2, 3, and AVF because those are the closest to the right atrium. You'll also see no isoelectric baseline. And in the case of variable conduction, we'll see that the ventricular response varies, which is the QRS complexes. So there'll be some sort of a pattern here. So it can be anywhere from 2 to 1, 3 to 1, 4 to 1, even 5, 6, 7 to 1 in some situations. The higher number or the first number is the number of atrial waves or atrial flutters. And then the 1 is the number of QRS complexes. So that's saying that for every 2 flutter waves, you're having 1 QRS, or for every 4 flutter waves, you're having 1 QRS. And in the case of variable conduction, that pattern is not consistent. So you'll see in this example EKG that we're alternating between a ratio of 2 to 1, 4 to 1. We're having 2 flutter waves for every 1 QRS, but then the next instance, there's 4 flutter waves for every 1 QRS. And this keeps changing. So this is what we mean by variable conduction, is that it's not a constant number of flutter waves that are then correlating with 1 QRS. And one little trick with atrial flutter is that sometimes if you're having a hard time figuring out if this is flutter or if this is fib, and if this is variable or constant conduction, if you turn the EKG upside down, sometimes it's actually easier to see the sawtooth pattern with the EKG upside down. It has to do with the way that the QRS complexes are aligned, and I find this helpful in practice. It helps me to be able to distinguish the more clear sawtooth pattern, because sometimes if you have like a 2 to 1 conduction pattern, it can be kind of hard to tell if this is flutter or if this is sinus tach. And sometimes even A-fib and A-flutter can look pretty similar if that A-fib has larger fibrillation waves. So again, you need to take a step back, get more samples if you need, so an extra EKG or longer down a telemetry strip to take a good look at what's going on with this patient. So how do we treat atrial flutter? Again, this is a very nuanced treatment similar to A-fib. So if you're going to rate control, you can use the classic 3 types of medications, the beta blockers, diltiazem, or verapamil. There's also a lot of situations where radiofrequency ablation is indicated, and that's because a lot of the time atrial flutter will cause much more of a problem because the atrial rate is so fast, and a lot of the times this is from an identifiable cause with a more discrete area that's causing this circuit entry. So it's a little bit easier to actually control with an ablation. Paradoxically, something to know is that antiarrhythmics can actually worsen the atrial flutter in certain situations, so you have to be careful with that. And if the decision is made to not completely ablate, or if the ablation fails and this person is going to have sustained atrial flutter, they do need anticoagulation, similar to the instance of A-fib. So here are some sources for this first part of the neurocomplex tachycardia episode. We will follow up with part 2 with the irregular rhythms. Thank you so much for joining us today on 10 Clinical Minutes, and we'll see you next time.